number of participants, almost going to 470. Today we are going to have a discussion on a very interesting topic. It's a topical issue, and it involves a study which has been ongoing in the Department of Obs and Gynae and also involving the Department of Pediatrics. And it's looking at the use of antenatal corticosteroids. This is an important aspect which is good for our well-being and the outcome of the newborns. So in order to take us through this presentation, which will cover the study which was being done in our country, it's a multi-center study. Other centers were in India, Pakistan, Bangladesh, Nigeria. And lots of work was put in this. The presenters and the discussant in this study will be our own. Dr. Kinuthia will give us a background of the project and what actually inspired and some of the guidelines which are being used in the use of antenatal corticosteroids. After he has completed his session, then Dr. Lavin will take us through the design and setup of the study. And this is one of the key areas which I would like you to pay attention to, because this is what informs the eventual outcome of the findings. And he will take us through what actually was done in our country and some of the sites in Kenya. Then the key area will be given by our own Professor Zaida Qureshi, who will then give us the results of the study findings. And this is where a lot of interest, I'm sure, will be generated, and several questions, I'm sure, will be generated from this. Then lastly, the implementation of the results and the need for setup, which will be given by my desk mate, Professor Fred Were. And after which, we will then have a session of questions and answers. We anticipate that the whole presentation should take approximately 45 minutes. Maybe if we stretch, could be about 50 minutes, but we really want to dedicate lots of time in discussion, because this is how we will be able to interrogate the study, look at the study findings, and then we look at the implementation of the results and how we can be able to translate the study findings into our clinical practice, which will inform, therefore, the improved outcome in our deliveries. So I would therefore ask Dr. Kinuthia to upload his slides. Please keep your questions up to the end, and then for those, for ease of reference, please post your questions on the chat. The relevant to be able to answer the question. We have two other study participants, that is Dr. Soti and Dr. Gwako. We will help in monitoring the questions in the charts, and where necessary, they'll be able to collapse the question so that you can be able to get proper. Dr. Kinuthia, the floor now is yours. Dr. Kinuthia, are we together?
Oh, sorry, I was on mute, sorry, thank you.
The floor is yours.
Thank you, Prof. Yes. So, thank you everyone who has joined. I'll give the background on the study, the code action trial, and basically talk about antenatal corticosteroids for improving preterm newborn survival in low resource settings. WHO defines preterm birth as birth before 37 completed weeks of gestation, or fewer than 259 days since the first day of the woman's last menstrual period. It is estimated that there are 15 million infants who are born premature globally, majority living in low and middle income countries. Preterm birth is a leading cause of neonatal and child mortality. It is estimated there are approximately 1 million newborn deaths that are due to preterm delivery. Infants who are born premature are at an increased risk for a wide range of short-term and long-term respiratory, infectious, metabolic, and neurologic conditions, with higher risks being for those who are born in the early preterm period. Antenatal corticosteroids have been considered the gold standard for treatment to reduce preterm birth-associated neonatal morbidity and mortality for decades. When steroids are administered antenatally, they cross the placenta and accelerate fetal lung maturity. Efficacy trials, which have been conducted mainly in large, high-resource countries, have demonstrated that steroids given to women at risk of preterm delivery are associated with reduced neonatal deaths, respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and systemic infections in the first 48 hours. The ACT trial, the antenatal corticosteroid trial in 2015, this was a community-based cluster randomized trial that was conducted in 6 low and middle income countries that included Guatemala, Kenya, Argentina, Zambia, India, and Pakistan. And the trial was evaluating feasibility and effectiveness and safety of a multi-phase intervention, which was designed to increase use of antenatal corticosteroids in the facilities. The study enrolled almost 100,000 mothers, and they were followed up for until 18 months. The primary outcome was neonatal death. The findings of the trial were actually quite surprising, because looking at the group of those infants who are born who are within the less than 5 percentile, when looking at mortality, they found there was no benefit of harm. If you look at the relative risk, it is 0.96 with a confidence interval that is crossing 1. So basically, there was no benefit for that group. Similarly, stillbirth rate was 0.9, relative risk was 0.99. And again, we can see the confidence interval with the conclusion that there was really no benefit or harm. Of concern was maternal infection, suspected maternal infection. There we can see the odds ratio is 1.67, is more than 1. So there is an obvious risk of infection for mothers in that group. Then looking at all the population, in total, in terms of neonatal deaths, we see that again, the relative risk is more than 1. It was 1.12, which indicated there was neonatal harm. Stillbirth relative risk was 1.11, again more than 1, indicating there was fetal harm. And infection, again, was more than 1. Odds ratio is 1.45, which means it's 45% higher, indicating that prescribing steroids during this trial was actually associated with increased risk of maternal harm. In 2015, around the same time, the WHO released guidelines which took into consideration the evidence of the ACT trial, but also an evaluation of the Cochrane review based on some of what I had shown previously as some of the anticipated benefits. But in this case, also taking into consideration concerns that steroids could lead to harm, and therefore came up with some consensus-based criteria for antenatal steroid use, which I'm sure you're all familiar with. And basically what they say is that, one, the steroids are recommended for women at risk for preterm birth from 24 weeks to 34 weeks of gestation when the following conditions have been met. One, that the gestation assessment has been done accurately, preterm birth is considered imminent, there is no risk of maternal infection, adequate childcare is available, and this includes capacity to recognize and safely manage preterm labor and birth, and also that preterm newborn can receive adequate care if needed, which includes a resuscitation, thermal care, feeding support, infection treatment, and safe oxygen use. So following the ACT trial results, which were quite surprising, a reappraisal of the Cochrane review evidence that had informed the decisions was made. And a number of things became clearer. One, the 30 trials which were included in the review were in high-level hospital settings in high-income countries. And with the exception of only one trial that was conducted in a low middle-income country, that is Tunisia. And obviously the level of maternal and newborn care provided in those facilities may not necessarily be what is available in our setting. Second, there was considerable heterogeneity in the eligibility criteria in those trials. The studies included or excluded women with certain obstetric characteristics, women in spontaneous preterm birth, women with premature rupture of membranes, rupture of membranes, women with planned births, women with other conditions such as multiple pregnancies, diabetes, or hypertensive disorders. Therefore, it was quite clear that there was a lot of heterogeneity in these data, which means that pooling of that data may probably not be very appropriate. It was noted that most of the trials were published before 2016, and many of the randomized trials were actually conducted over 20 years ago, before that time. While the age of a trial in itself is not necessarily an indication of poor quality of the trial, it's also important to keep in mind that reports of older trials often have or may contain insufficient information to fully assess the risk of bias. And also, it's also important to keep in mind that in over a period of almost 30 years, the context of maternal and newborn care has changed. So it may not be very appropriate to use those studies. In addition, most of these studies were very small. They had very small population. Most of them had less than 200 women. Also, although the primary outcome in many cases was neonatal mortality, but no trial was powered to assess neonatal mortality, and often was not measured post-discharge from the hospital. Also, it was found that actually when you looked at the data from the larger trials, there was really very small or no clinical benefit. So based on this information, it seems it was based on this, a reevaluation of this data, it seemed there was clearly a case of clinical equipoise for use of adrenal corticosteroids. And therefore, there was need to conduct efficacy trials of steroids in these settings to inform clinical practice. That was the background for the ACT trial. And I'm going to hand over to Dr. Ahmed Lavin to go on and tell us how the design and how the study was conducted. Dr. Lavin?
Thank you, Dr. Kenothia. If you can continue projecting the slides, please. Okay. So next slide, please. Yes, so the ACTION trial was basically a multi-country, multi-center, double-blind, randomized placebo-controlled trial to compare intramuscular dexamethasone with identical placebo in women at risk of imminent preterm birth. It was conducted at 29 secondary and tertiary level hospitals across 6 trial sites in the countries mentioned by Dr. Kenothia. That's Bangladesh, India, Kenya, Nigeria, and Pakistan. Next slide, please. So the participants were pregnant women between the ages of 26 weeks to 33 weeks, 6 days gestation, who are at risk of imminent preterm birth. The intervention was a course of 6 milligrams dexamethasone iron injections every 12 hours for a maximum of 4 doses, or until hospital discharge or birth. And if the women had not delivered by 7 days and still met the inclusion criteria, that's still before 34 completed weeks, and they went into labor again, preterm labor again, a single repeat course of dexamethasone was used. The comparison was an identical saline placebo. The primary outcomes were 1, neonatal death, 2, any baby death, stillbirth or neonatal death post-randomization, and 3, possible maternal bacterial infections, defined as maternal fever more than 38 degrees, suspected or confirmed infection for which antibiotics were used. Secondary outcomes were maternal and newborn morbidity parameters, and those were specified, as well as healthcare interventions and health service utilization outcomes. As mentioned before, the setting was in resource-limited hospitals in the countries listed, and the hospitals were selected on assessment of availability of maternal and newborn services. And it was hoped that these facilities would have minimum out-referral of women who are at risk of imminent preterm birth. These facilities also should, or rather met the WHO trial criteria, which included availability of emergency obstetric care, as well as preterm and newborn care availability, which included resuscitation at birth, thermal care, breast milk, feeding support, parenteral antibiotic treatment if necessary, safe oxygen use, as well as access to CPAP and hygiene. And since we know the challenges, especially equipment challenges in resource-limited settings, all the hospitals were provided with ultrasound machines, CPAP machines, pulse oximeters, and glucometers to ensure that at least minimum quality of care was received by trial participants. So the Kenyan study sites were 4: Coast General Hospital, Kiambu Level 5 Hospital, Thika Level 5 Hospital, and Nakuru Level 5 Hospital. These hospitals met the criteria. We went through multiple levels of approvals from the Kenyatta National Hospital, University of Nairobi Ethics Research Committee to the Pharmacy and Poisons Board, because this was a placebo-controlled trial involving medication, to NACOSTI, and Coast General Hospital also had its own Ethics and Research Committee approval. The principal investigators were Professor Qureshi, Professor Were, and Dr. Kinuthia. The co-principal investigators were Dr. Gwako, Dr. Osoti, and myself. And the site coordinators were Drs. Nawal, Buga, Njoroge, and Barasa, under whom the obstetricians, pediatricians, ultrasonographers, and pharmacists were reporting, as well as the hospital nurses. And each study site had 2 study nurses who are then helped by the hospital nurses when during off hours. We had a data clerk, Irene, our data manager, Mike, and our study coordinator was Harriet Baraka. So how did we screen and recruit the women? So pregnant women who had confirmed live fetuses between 26 weeks and 33 weeks, 6 days of gestation, and who are at risk of a preterm birth, which was defined as planned or expected birth in the next 48 hours, which was either provider-initiated preterm birth or after preterm, premature rupture of membranes, or spontaneous labor. The gestational age had to have been determined by ultrasound either early in the pregnancy or one was done at admission. Women were excluded if they had signs of severe infection, if there were major congenital fetal abnormalities seen on ultrasound, if the women were on concurrent or recent using systemic steroids recently in the last 2 weeks, if they had any contraindications to corticosteroids, or if they were participating in another trial. And written informed consent was obtained from all participants. So as mentioned earlier, the trial provided certain sets of equipment to all study sites, which included CPAP machines, and we had 4 CPAP machines provided at each study site, a Philips ultrasound machine, as well as multiple pulse oximeters, both the mounted ones as well as the portable ones. The site coordinator was in charge of the overall coordination of the study activities. There are the 4 site coordinators, and the activities included screening, consenting, and randomization, which was done by the study nurses. They are also responsible for administering the study drugs and monitoring the blood sugar levels for the babies. And as I mentioned, they were helped by the hospital nurses when they were not around. The pediatricians and neonatologists would assess the gestational age of the neonate using the Ballard scoring system, and the sonographer or the radiologist would perform a transcranial ultrasound as indicated. And the follow-up was done by the study nurses on day 7 and day 28. So some nice pictures of the trainings. The initial trial training was in December 2017. And then 6 months later, there was training for the study nurses. And then the ultrasound training some photos of ultrasound training done at Thika Level 5 hospital with an international trainer who came specifically to teach people how to do this obstetric as well as neonatal ultrasounds. Next, please. And we had several site visits as well as a few CMEs. So photos showing CME in Kiambu as well as Nakuru. And the last photo is some sensitization training going on at Coast General Hospital in Mombasa. Thank you.
Thank you, Dr. Lavin. At this point now, I would like to call upon Professor Qureshi to give a presentation on the results of the trial, the findings. Professor Qureshi.
I'm trying to share. Good afternoon, everyone. Okay, as I was introduced, I'm Professor Zahida Qureshi from the Department of Obstetrics and Gynecology, and it's now my pleasure to present to you the results of the Action-1 trial. So this is a busy slide, but I do not expect you to go through it. I just want to share with you the fact that over 7,000 women were assessed for eligibility, which is they were screened, and 2,852 of them underwent randomization, and they were almost equally distributed into the two arms of the trial, which is the dexamethasone and the placebo arm. And then being very well balanced, the ones who were assessed for the primary outcomes were 1,416 and 1,412, respectively, in the two arms. So we had women who were to receive antenatal corticosteroids if they met all the inclusion criteria. And the most common reason for the ones who were screened but were not included were that birth was not planned or expected in the following or the next 48 hours from the time we randomized them. And we had over 99% completed follow-up. All the women in this trial, except one, received at least one dose of the steroid. Of course, if a woman would come in and receive and then she would deliver, she would have received only one or two of the doses. 57% of the women in the dexamethasone arm and 53% of those in the placebo arm received all the 4 doses of the first course of the trial medication. And the use of repeat course was minimal. Remember, Dr. Loving told us that if a woman did not deliver, but over a week later, she still met the criteria for risk of preterm labor, then she could receive a second course. So looking at the characteristics of the participants at trial entry, the indication for trial entry was largely spontaneous preterm birth in over 61 to 60% in the two arms. Provider-initiated preterm birth was then the remaining, which was around 38 to 39%. The mean gestational age at trial entry was just over 30 weeks for the two arms. And the ultrasound that was performed either earlier or at trial entry, which was used to estimate the gestational age, was largely in the third trimester at around 65 to 66%. Very few women had had an ultrasound in the first trimester, just over 10%, and about 23 to 24% had had a second trimester ultrasound. The medications that we looked at, which had been provided to the women prior to randomization, and we looked at tocolytics, which were around 17 to 18% for the two arms. And magnesium sulfate for fetal neural protection was low, but a slight variation in the two arms. For the dexamethasone arm, it was 9.9 and 12.6 for the placebo arm. We now come to look at the primary outcomes. And we see that for dexamethasone, neonatal death was 19.6%, and for placebo, it was 23.5%, giving us a relative risk of 0.84 and a p-value of 0.03. And you can see this is not reaching the 1. So this is a significant finding. Stillbirth or neonatal death for the dexamethasone arm was 25.7%, and for the placebo arm was 29.2%, with a relative risk of 0.88 and a p-value of 0.04. And for possible maternal bacterial infection, we had 4.8 in the dexamethasone arm and 6.3 for the placebo arm, with a relative risk of 0.76. And the possible maternal bacterial infection outcome was planned, and the p-value for this was calculated for non-inferiority. So there was no additional risk of maternal infection. Coming now to the secondary neonatal outcomes. So we looked at stillbirth, early neonatal death at less than or equal to 7 days, severe respiratory distress, any respiratory distress, any respiratory distress, respiratory distress at 24 hours, neonatal sepsis, any hypoglycemia, and hypoglycemia at 6 hours. So let's look at those which have an asterisk and which are the important ones. So for early neonatal death at less than or equal to 7 days, in the dexamethasone arm, this was 15.4 versus 19.1 in the placebo arm, and had a relative risk of 0.81, which was 0.08 to 0.96. Severe respiratory distress at 24 hours was 3% in the dexamethasone arm and 5.5 in the placebo arm, with a relative risk of 0.56. And hypoglycemia at 6 hours was 7.5% in the dexamethasone arm and 10.3 in the placebo arm, with a relative risk of 0.73. And the severe respiratory distress was measured from initial postnatal hospitalization until death, discharge, or completion of day 7. We continue with other neonatal secondary outcomes, and these were APGAR score of less than 7 at 5 minutes, major resuscitation at birth, and then use of several interventions such as oxygen use, CPAP, mechanical ventilation, parenteral antibiotics as a treatment, surfactant, or admission to a special care unit or newborn readmission. And out of these secondary neonatal outcomes, major resuscitation at birth, we had 7.3% for dexamethasone arm and 10.4 for the placebo arm, with a relative risk of 0.70. And use of CPAP was 18.5% for the dexamethasone arm and 23.9% for the placebo arm, with a relative risk of 0.78. Moving on now to the maternal secondary outcomes, we looked at death, fever, and various indicators of infection such as chorioamnionitis, endometritis, wound infection, non-obstetric infection, and treatment by use of therapeutic antibiotics, any antibiotic use, or postpartum readmission. And if you look at the table, these were almost equally balanced in the two arms. What I would like to point out is that any antibiotic use in this trial was very, very high. It was at 89%, 89.1 and 89.7%. So there was a lot of use of antibiotics in this population. Coming now to the cause of neonatal death for the babies who died in this trial, out of the ones in both arms, we looked at perinatal asphyxia, respiratory distress, neonatal sepsis, other specific causes, and those who the death could not be determined. So in this data set, we have respiratory distress syndrome, 8% in the dexamethasone arm and 11.1 in the placebo arm, with a relative risk of 0.72. There were also pre-specified subgroup analysis of the primary outcomes, and these were whether preterm birth was planned or not. So for all of these that I'm going to read out, there was no interaction if preterm birth was planned or not, gestational age at first dose, number of fetuses, the study site, mode of birth, and the time from the first dose to birth. There was an interaction for use of tocolytic agent before preterm birth with a p-value of 0.03. So the study results were published in the New England Journal of Medicine, online version on October 23rd, and the print copy in December 2020. In the print version, the commentary, or the editorial, sorry, was based on this trial. So I am going to end my presentation and hand over to Professor Were to give us what the implications of these results are. And I will come back after Professor Were just to give the acknowledgements to the sites.
Hello?
Yes, Fred, go ahead.
Yes. There are no slides floating somewhere?
Not yet, not yet.
Zahida, were there not a couple of slides?
Very many, Professor. They were sent to you to look at.
Yeah, but they should be back here. But they're not on this deck. The presenter is not having, the host is not having them. Hello?
Let's inquire from Dr. Kinu.
Yeah, let's ask Dr. Kinuthia.
The same, the action, the newborn survival side of things, to look at the implications in our kind of countries. Move to the next one. This is guided by, basically the need to do this was guided by lots of work in the previous year, dating back to the New Zealander Liggins in 1972, who have indicated by various levels that there is some benefit, there is no benefit, there is some neutrality, with some eventual overall 2016 Gimfi Bannerman finding that there was probably harm rather than benefit, though crossing the midline. So it's this degree of confusion on the newborn side of things, uncertainty, that warranted us to look again and probably that's what would have permitted at that level to do a randomized control trial in an intervention that was already in use and accepted as a guideline. Next slide. So in that preparation then, a large base of evidence was looked at again. In this respect, look at the stillbirths as an outcome. And where that was concerned, there appeared to be no actual harm when you give antenatal corticosteroids in stillbirth rates. That has been a question by some isolated findings and quite a few opinions that felt that this probably can harm the unborn newborn. The next one. Then the overall perinatal death, which it's the newborn, well, the first 1 week and the 1 week before delivery was also looked at. And again, the available information was not at that time indicating that there is any actual harm, though there's a drag towards harm, but not crossing the middle. So statistically, we would say that that was no really difference. Next. Then, of course, the big one for the newborn, our biggest fear, the biggest cause of our bad outcomes in the newborn period for those who are born premature is RDS. So looking all through the previous studies, when you use antenatal corticosteroids, the lots of them that tended to say it favored a lower incidence of severe RDS or any RDS for that matter. But again, the WHO pulled together the data and agreed that there is actually where the cancer is just touching, the overall odds ratio was telling us that there is benefit when it comes to that. But lots of the studies, again, were crossing and hinging, a few, not that many, hinging on the other direction. So it permitted some further inquiry, these findings. But these were what will advise the earlier guidelines. Next. So then the global evidence summary from a Cochrane evaluation is summarized by this busy looking slide with some 15 trials that are looking at singleton pregnancy. We have some 12 trials that including multiple pregnancy, 10 coming from our kind of environment, Kenya, middle and lower middle, and 17, of course, from the higher income, and 19 studies using a single course of steroids, and some using a single course or repeated doses. So a lot of those have been included in this Cochrane systematic review. And for babies, there has been then evidence of so a high 2.3-fold fewer perinatal deaths when antenatal corticosteroids are used in a timely way, 2.6% fewer neonatal deaths, 4.3% fewer cases of RDS, which is the nemesis of neonatologists in a sick baby. And where there's modest certainty of evidence, that is where the certainty of evidence that is high, and that is in the bigger countries that have probably more refined follow-up abilities. Where there's some mild evidence, less convincing but still present, is that we obtain nearly 1.5% decrease in intraventricular hemorrhages among the worrisome early neonatal complications that lead to developmental defects. Mothers with the demonstrated among the mothers very little maternal death, probably none, chorioamnionitis, no difference, and then endometriosis, no difference. So this evidence was up to probably 2020, indicating that there is value in antenatal corticosteroids. Next. So that put together the implications for national policies and implementation in low middle income countries where we officially exist as Kenya, that we need firm government commitment to safely scaling up antenatal corticosteroids administration where the treatment criteria has been met. We need well-planned and participatory consensus-driven processes of adaptation and implementation. There's need for development or updating of national guidelines and protocols based on the latest research. We have existing ones in Kenya actually, but even they require that we relook at them from time to time. An enabling environment for safe antenatal corticosteroids use, avoiding things like stockout and making all facilities able to provide it is a requirement, is probably a good thing to do. We should make it a requirement. There was always need for training healthcare workers because even during our trial, there were lots of people who are giving, not giving, and various reasons given were not even among the contraindications that exist. A clear referral pathway is required for women at risk of preterm labor, so that they probably move to places that would have the know-how of safely administering corticosteroids. So the adverse effects from preterm birth will only be achieved at all those levels. Government commitment, national guidelines that are updated regularly, an enabled environment as a delivery place that has the various things that Dr. Lavin was describing earlier, healthcare staff training. You can never underestimate that. And a network of care. A country like Kenya is pretty big. We exist in 48 different environments of health systems. So even locally, we require a very serious network to obtain a bit of equity in what can benefit our preterm babies. Next. So I think this slide has been shared before. The body of people that were part of the action trial, from WHO to the countries Bangladesh, India, Kenya, ourselves here. And the next one is actually thanking the big brothers and sisters that avail the funds. And those that, even if they didn't avail the funds, like University of Nairobi, Kenyatta Hospital, and the places that permitted the studies to take place. I think that should be there. Another one?
No,
Oh,
that's fine.
right.
Thank you.
Yeah, thank you. So that is our side of things. And I'm sure Professor Qureshi or Dr. Lavin mentioned I had a bit of trouble getting in, how we were stopped in the course of work because we had proved the point earlier, and it became unethical to continue giving anybody placebo. So that's always something worth noting, that it's a study that has been well implemented. So you must thank all those involved to be able to prove the point halfway through. That is usually a measure of good quality of research. Thank you.
Thank you very much, Professor Were. Can I be heard?
Yes, very clearly by me.
Okay. Good. So I just want to continue with the acknowledgements. This was, as we said, led by WHO through funding by the Bill and Melinda Gates Foundation and those various organizations mentioned here in the various countries. Locally, I would like to thank all the
I'm
4
not sure
trial
I deserve
sites.
the lunch, but...
Okay, so we have Nakuru level 5. And
I'm
all
saying, since I'm concentrating on antenatal corticosteroids, maybe Irene might withdraw this from her bill.
Professor Were, you need to mute yourself, please.
Oh, you are hearing me?
Yes. So I would like to thank all the facilities, the nurses in all the facilities, the OBGYNs, pediatricians, the staff from the administration who were very, very supportive. And it was just a nice finding that in all the sites that we were at, each one of them moved to a new facility or new maternal newborn unit during the time of our trial. In Kenya, the trial ran from October 2018 to November 2019. So this is Nakuru. They have a new unit, Margaret Kenyatta Mother and Baby Wing, a very, very beautiful unit. You can see all of us visiting them, and we've visited them many, many times. Kiambu level, it's level 5. That time it was still level 4. You can see us doing our visits. Then we started off.
Are you sharing your slides?
Are you not seeing them? Sorry, I thought I
was.
was.
On my side.
There are no slides.
Yeah.
Oh gosh, and nobody told me.
Okay, they are on.
We were shy.
Are they on now? Okay, okay, sorry.
Yeah, can start there.
Okay, fine. So this is the new wing of Nakuru Level 5 Hospital, which is called the Margaret Kenyatta Mother and Baby Wing. Dr. Ogindo, Dr. Barasa, and all of us visiting them. Kiambu was then level 4. You can see we started off with Dr. Waweru, Salome Waweru. We had a change. She moved to another facility. So during the study period, we had several changes in OBGYN and the neonatology staff members, and also the heads of the maternity and the newborn units. Thika level 5, Dr. Joroge and Dr. Thuranira, and Coast General, we started off with Dr. Hafsa and we moved to Dr. Nawal. We also had visitors from WHO visiting. You can see here in this picture on the lower left with Professor Were accompanying his visitors from Geneva. And in the meantime, the Coast General had a big new newborn unit put up with the support of Safaricom. And us in the top visiting Geneva for the last meeting, and then all of us having an update meeting. And I would like to, I'm just putting this picture on the right side, who is Joshua Vogel. We almost gave him a temporary Kenyan citizenship because he visited us so many times. And what I would like to share with you in his picture on the right is it's against the Cochrane logo. And the Cochrane logo is actually based on the antenatal corticosteroid trials. And he and I joked one day and said, what if our trial proves that antenatal corticosteroids are not beneficial? What will happen to this logo? And we were both very happy that our trial proved that antenatal corticosteroids are beneficial. You need to treat 25 women to prevent 1 newborn death. And those are my final words, and I will now hand over to the moderator. Thank you very much.
Thank you, Professor Zaida Qureshi, for those kind remarks and acknowledging the participants. Ladies and gentlemen, colleagues, you have gone through the presentation. We started with Dr. Kinuthia, who is a senior consultant at Kenyatta National Hospital in charge of the research unit and one of the co-investigators in the program, giving us a background. Then we came to Dr. Lavin, who is a senior lecturer neonatologist at the Department of Pediatrics and Child Health at the University of Nairobi. Then giving us the study design and the setup. Professor Qureshi, who has just spoken, who is an associate professor in the Department of Obstetrics and Gynae, and one of the PIs, gave us the results of the study. And she has also given us an acknowledgement and some of the nice remarks about their study findings. And lastly, I've finished Professor Fred Were, who is a professor of neonatology and our former principal, giving us an output of what the implementation of the study findings and the next steps which we need to put in place so that we can be able to benefit from the findings of this study. Now, we had promised that we'll take about 45-50 minutes in the presentation. The presenters have actually almost kept to their word because we started about 5 minutes late, and it's now some minutes to 3 o'clock. So at this point, we'd like to interact with you and hear any concerns which can now be, we have our able team, the co-investigators, Dr. Guaco, who is a lecturer in the Department of Obstetrics and Gynae, and Dr. Osoti, who is a senior lecturer in the Department of Obs and Gynae, to be able to go through the chat box, summarize some of the questions and then raise them. Then we can now have the panelists being able to answer the questions as raised. We have at least 30 minutes to be able to interact. Dr. Guaco and Dr. Soti, could you start with any of the questions in the chat box? The ones mmeshachambua mkaweka tayari.
Yeah, the first question, thank you for the panelists for the great presentation. The first question that I would want expanded on is on the why we chose 26 weeks and not 24 weeks. So maybe Professor Qureshi, if you can answer that as the lower gestational age.
Okay, so WHO actually recommends that we can start from 24 weeks. But looking at the fact that we were going to get a very, very small group of women who would be between 24 and 26 weeks, the fact that we needed to have a large amount of sample size for this study, it was felt that for the sake of this research activity, we would be better off, or it would be better for the study design and for the participants that we were recruiting to actually start at 26 weeks. Remember, this is low middle income countries. And in low and middle income countries, we also sometimes tend to say, okay, is 28 weeks the cutoff? But we do know that from 26 weeks onwards, there's a very, very good chance of the baby surviving, provided you have all the necessary equipment, supplies, and care for that newborn. And that's the reason 26 weeks was chosen for this study.
Thank you, Professor Qureshi. Dr. Kinuthia, there's a consistent question that is coming up asking why dexamethasone and not any other steroids like betamethasone. Maybe if you can respond to that.
Yeah, this was a consensus decision on what steroid to use, although we know that in terms of availability, dexamethasone is within our essential kits, essential medicines kit. So in terms of availability, that was not going to be a challenge. Also in terms of the cost, it was also going to be a challenge. So this was based on consensus, on discussion on what would be most feasible to implement. However, there is also a new study we are going to be starting, Action 3, which is also going to be using betamethasone. And some of the concerns have to do with the same issues I've talked about: the cost, the fact that it's still not available readily for use in our public health system. Thank you.
Okay, thank you. A question to Professor Were, that the newborns in low middle income countries tend to we have challenges with neonatal care for our newborns in low and middle income countries. Was this a pragmatic trial in that we did what we normally do for newborns in low and middle income countries, or we had different management for those in the study compared to what we do in low and middle income countries? So maybe if you can expand on the changes in the newborn care in the study versus in the usual setting.
The intervention aimed to do what we should be doing at those levels of hospitals in the lower middle income countries. That's why we insisted on availability of ultrasound, even for kernel ultrasound, availability of the main treatment of respiratory distress syndrome at present in the world, which is CPAP. So we went beyond the normal, but basically this is what has been prescribed presently by even WHO as an essential requirement for a unit that is said to be prepared for looking after the small baby. So if you look at the state of the art as we do it in any private, in any district hospital now, we went beyond that. We aim to do what is described as properly reasonable minimal care for preterm newborns. And importantly, it was the introduction of appropriately utilized CPAP. It's one of those things that I recommended in every other guideline and utilize almost nowhere in our zone. So respiratory care was important. Monitoring saturation was a component, which we feel is doable by many of these facilities in these regions. Cheaper forms of CPAP, the bubble and all those, which is what we used. We used something higher than that. But we did not go to the basic that all of you remember. When you go to smaller hospitals, we went a bit beyond that, sort of what we think should be the minimum for the levels of hospitals that we chose. Thank you.
Thank you, Professor Were. Back to Professor Qureshi again. Could you comment on the gestational age cutoff? Because there are questions about use of antenatal corticosteroids after 34 weeks. So somebody's asking, could there have been a benefit if we went to 37 weeks? And is there a benefit of giving steroids beyond 37 weeks? So maybe if you can give a comment on that.
I hope I'll be around in 48 months, maximum of 36 when action 3 is reported. That's what it's dealing with, the bigger baby. Let me leave it there. Yep.
So just to add on to what Professor Were has said, we are calling this the results that we are presenting as Action 1. So this was the trial for early preterm babies, which was from 26 weeks up to 33 weeks and 6 days. We had a second trial, which was then from 34 weeks to 36 weeks and 6 days. All the countries that participated in Action 1 were supposed to do Action 2 as well. But it only started in India, and then the DSMB actually had to stop it on the basis of futility. What we are now going to start in the next few months is what we are calling Action 3. And we are going to look at this same question for the late preterms. So hopefully 2 years down the line, inshallah, we will present to you those results. So yes, that is something that is now not in the guidelines. People give it when they feel like. There was a trial conducted in America called the ALPS trial, which looked at antenatal corticosteroids for late preterms. But even after the findings, it has never translated into practice. So we need to answer that question through research, robust research, just as the one we did this, as we did this one. Thank you.
2 years, I hope I'll still be in service.
That is why I said, inshallah, Professor.
Oh, that's what that means, eh?
Yeah.
Good.
God willing.
Okay. Question from Dr. Wasuna. Do you want to ask the question yourself? Maybe you can unmute him so that he can ask.
I think I've posted it very clearly in the chat. I may have missed it, but it didn't come out clearly whether there were any ladies who delivered in under 24 hours after the first dose of dexamethasone. That's the first question.
Correction, that is Professor Wasuna, not Dr.
Sorry,
Wasuna.
I know my peer. Sorry, Professor Wasuna.
It doesn't matter.
We are okay with those titles. Pediatricians are modest people. Don't worry about it. We are not so sure about the other members of this group on modesty. But maybe, Professor Qureshi, you can say something about that.
Don't mind.
Yes, Professor Wasuna, thank you for that question. So you're asking, were all mothers in the delivering at least 24 hours? No, there were some women who did deliver. It's staggered. A few women delivered after just one dose, others after 2, after 3. But the 53 and 57% I presented were those who received the entire 4 doses of the medication.
Yes, but from the first dose
yes.
delivery, from the first dose to delivery, was there anybody who delivered in under 24 hours?
Yes, they did. They did. Between the first and the second dose, they did. And wherever they delivered, there was evidence of benefit. So we were also surprised to see that we had thought that women would have had to receive at least 2 to 3 doses before there was benefit, but even the 1 dose did show a modest benefit.
So you are saying that nobody delivered in under 24 hours?
No, they did.
Dose.
They did. Several women did. We have the percentages with us. We didn't just present them here. Yes, there were women who delivered after the first dose, but a small percentage.
In under 24 hours. I'm asking about the time, Zaida.
Yes. Yes, Professor Wasuna, there is a percentage of women in the entire data set who delivered after the first dose, which means you give them the first dose and before it's time for them to have the next dose, they delivered. Yes, there is a percentage of them who did deliver, yes.
And they were included in the computation of your results?
Yes, they were, yes. All women who were randomized, who received even 1 dose, all of them were analyzed.
You think they would have confounded the results you got?
No, they did not confound the results.
That was tested statistically?
Yes, it was tested statistically, yes.
It was more dangerous for us to avoid the intention to treat, agree? We'd have been in trouble.
Yeah, but you may have to look at them as a separate set to see what effect they have. Now, the second question is, I did see that you diagnosed a couple of asphyxiated preterms, and I'm just perplexed. How do you diagnose them?
Professor Where you need to take this.
Professor Were, the diagnosis of asphyxia, yes, in the study, or Dr. Lavin, one of you.
APGAR score and an attempt to do encephalopathy scoring, which is not done very consistently and often enough. Sorry.
Yeah, because that is extremely weak link in that diagnosis. And I would suggest that you don't even go there. If you're going to put them in analysis as asphyxia, that is totally misleading. And the last comment is that the study is very refreshingly confirming what is now established as an essential intervention and in imminent preterm births. So I think you have just reconfirmed what is now established, and that is very refreshing. Thanks.
Thank you.
I don't mind, as you grow older, titles don't matter.
Exactly.
Thank you, Professor. Another question, maybe this is to Dr. Lavin, just to clarify. Is there a possibility of following this neonates, or did you plan to follow the neonates beyond the 6 weeks or up to 1 year postpartum?
Thank you. So as far as the study is concerned, the study is closed. We follow till 28 days. However, there is a possibility, because we have data and many of these women come back for the clinics, postnatal and well-baby clinics, to the same hospitals. So it is something that we could look into, but it was not part of the study protocol.
Okay, thank you. I think we've answered most of the questions. If there's any other burning question, then we can try and answer them, or you can just ask them, then we can answer them. Otherwise, back to you, Professor Omondi Ogutu.
There's still some other questions in the chat where I think Joshua is asking if this study was only limited to dexamethasone, or was there any other steroid involved? I think that one they have clarified, but maybe Dr. Kinuthia can talk about that. And then this is what the study, somebody anonymous attendee, is it correct to say the benefits of using steroids are minimal? I think the study findings are shown otherwise. Professor Qureshi can comment on that again. And then Dr. Kinuthia or Professor Qureshi, you can comment on why you chose, was it DEXA, or did you use any other steroids? Just to clarify what Joshua and anonymous attendee is also as addressed here.
Yes, I'll start. And thank you, Prof. I'll start and say that for this study, we had 2 study drugs. So one was dexamethasone, and the other was a placebo. Remember, we said this was a blinded RCT. So we only used dexamethasone. And the choice of dexamethasone was because it is already part of the essential drugs package. There are also the benefits of cost. It is relatively and also relatively available in our setting. In the new study that Prof. Qureshi talked about, they will also be using betamethasone. But for this one, it was dexamethasone that was used. Thank you.
Professor Ogutu, I just see another question in the chat box from Dr. Anthony Van Neuro. Did we have any post-delivery follow-up? I think Dr. Loving did answer, but no, our follow-up was just up to 28 days.
Okay, maybe something I could see it was there, but maybe Prof. Were or Professor Qureshi can clarify. There's something, and this is something which everybody always talks about in the use of in the preterms when you use steroids. Do you enhance neonatal? Was there any difference in the finding on neonatal sepsis in the placebo arm vis-a-vis the dexamethasone arm?
No difference here.
Thank you.
That was an agreement with many previous workers.
Okay. Because there's been always some people who say that if you give it in neonate, because may suppress the response, and therefore some babies may get septicemia. And of course, evidence has shown otherwise, which your study has actually confirmed.
Indeed.
Do you have any other comments on the chat box? I can see Dr. Kinuthia, your team is now populating us with adverts of the coming webinars, so we cannot be able to access what is in the chat because it's now. Okay, thank you, thank you.
You should dismiss us then, James.
Okay. So this, I don't see any other comments. Unless maybe Dr. Scott, you have seen any, because it seems like people have actually exhausted.
No, all questions have been answered. The ones that we have not responded to already have been answered in the chat box. And one which is persistently coming up is the use beyond 34 weeks. It was beyond the scope of the study, 37 weeks. It was beyond the scope of the study to go beyond 34 weeks. And as Professor Qureshi had mentioned, that there was Action 2 trial that went beyond 34 weeks, but not beyond 37 weeks. So there is some evidence, but that is not within the scope of this trial. So that may be answered in another trial. That's why we are trying not to answer it now. Thank you.
Okay, I think now we are at 3:17. The webinar is supposed to end at 3:30, but in the event that we have addressed all matters raised in the chat box, and the presenters have actually eloquently given us the findings from the study, I think maybe therefore at this point we may need to sum up and say thank you all of you. We had over 1,000 plus attendees. I think this is one of the most well-attended webinars, and the attendees were from within and also outside the country, and also even in the other areas in the other continents, which is a plus to the presenters. And I think your message has actually been delivered clearly. And those who attended this session have really come out with lesson learned that use of corticosteroids in the preterm is beneficial. Risks are minimal, but you have to choose your patient correctly so that you don't just give it to anybody. That let's give each and every of the presenters a clap, and then we also thank Dr. Kinuthia for being able host who has hosted this webinar in their platform. And with that, I would say thank you to all. I'm Omondi Ogutu. I'm the chair of the Department of Obs and Gynae, and we'll welcome you to another session coordinated by the Department of Obs Gynae and also with the Department of Pediatrics. Thank you, ladies and gentlemen, and have a nice day. Thank you.
Thank you.
Everyone.
Bye-bye.
Bye.
Bye.
Bye.